Break this into two lectures. So we're going to do mechanics of breathing, straight up physiology for the most part today, with a little bit of a clinical twist. And then the next time I come back, we'll do mechanics of breathing during mechanical ventilation. So we'll talk more about assessing mechanics when patients are on ventilators and so forth. So we have done ventilation, diffusion, blood flow, gas exchange, gas transport, acid base, and now we are up to mechanics. So we are reaching the end of this series of lectures on respiratory physiology. A couple more months and we will have to decide what we're going to do after this. So in the first lecture we talked about ventilation, and we said that the arterial PCO2 was determined by metabolic rate, CO2 production, minute ventilation, and dead space. So if your dead space goes up, either your minute ventilation has to go up or your PCO2 has to go up, or both. If CO2 production goes up, PCO2 will go up unless minute ventilation increases and so forth. So that was week one. Then week two we talked about diffusion across the alveolar capillary membrane, which is determined by a number of things, primarily the surface area for diffusion and the thickness of the membrane. So if there's loss of surface area, like with emphysema, that will reduce diffusion. If there's thickening of the alveolar capillary membrane, like interstitial lung disease, that will decrease diffusion. And then in the third lecture, we talked about blood flow through the lungs, and we talked about things that affect blood flow through the lungs, like how much pressure there is in the pulmonary vasculature, what the lung volume is, and how we can affect pulmonary blood flow by inhaled pulmonary vasodilators, specifically selective pulmonary vasodilators. And then we talked about ventilation perfusion matching, and we had said that there are two extremes along the continuum of VQ matching. So in one extreme we have ventilation without blood flow, that's dead space. At the other extreme we have blood flow without ventilation, that's shunt. And then normally ventilation and blood flow are appropriately matched, which leads to normal blood gases. And then last time we talked about gas transport, which is very hemoglobin dependent, and we talked about the oxyhemoglobin dissociation curve in some detail, and we also talked about the CO2 dissociation curve, and we had pointed out, for example, if we increase oxygen saturation, that will shift the CO2 diffusion curve, so CO2 will be offloaded from hemoglobin, which explains why the PCO2 goes up when we give some patients oxygen. So that then brings us to respiratory mechanics. So today, we're going to talk a fair amount about the actions of the respiratory muscles and how that can be assessed and how we can determine if a patient has diaphragm paralysis, for example. We will describe the normal pressure-volume relationships of the lungs, chest wall, and respiratory system. Next time we will talk about that in more detail as it applies to disease like ARDS. We'll explain the important function of surfactant in the lungs. We'll discuss the effects of the pleural pressure gradient. So the pleural pressure is not uniform throughout the thorax, and we'll talk about why that is important. We will compare laminar and turbulent flow. We'll describe the effects of the equal pressure point, so why it is if you blow out harder, there's not more flow that comes out of the lungs. And then we'll use the time constant to explain the distribution of gas flow. So a lot to cover. So the respiratory muscles, so we can think about respiratory muscles in terms of the inspiratory muscles and the expiratory muscles. The primary muscle of respiration, as you know, is the diaphragm, and that accounts for the predominant movement of gas into the lungs during inspiration. The diaphragm is an inspiratory muscle. During exhalation, it is passive, so it should not be contracting at all during exhalation. The external intercostal muscles are also important during inspiration, so most of inspiration is due to the diaphragm, a little bit of it due to the external intercostals, and then there are a number of accessory muscles that are only used during stress. So we use our accessory muscles when we exercise, for example, or if we exercise, maybe I should say. Exhalation is normally passive. So normally we don't need to use any muscles to push the gas back out of the lungs. So as you are breathing now passively, the gas comes back out of the lungs due to the elastic recoil pressure of the respiratory system. So no muscles are needed for exhalation, but with stress, like during exercise, there are a number of expiratory muscles that can be activated, and they are primarily the abdominal muscles and also the internal intercostal muscles. So some of that is illustrated here. So when the diaphragm contracts during inspiration, the diaphragm moves downward, and also the diaphragm pushes out on the rib cage. So there are actually two actions of the diaphragm, which are to pull the lungs downward, so the gas inflates into the lungs, and also to push the rib cage outward. And in fact, in individuals who have a lowered flattened diaphragm, like patients with severe COPD, when the diaphragm contracts, it does not move downward, and it pulls the rib cage inward. And that's something on physical exam called the Hoover sign, where in patients with severe COPD, they breathe in, and you see the lateral rib cage going in rather than out, because the diaphragm is pushed downward and cannot contract downward. So during inspiration, the diaphragm contracts downward. During exhalation, the diaphragm is passive. So the diaphragm is not activated during exhalation. The diaphragm does not push gas back out of the lungs. The abdominal muscles, when they contract, move the abdomen inward. That will tend to push gas out of the lungs, such as with exercise, but normally the abdominal muscles are passive. And then illustrated here is the position of a number of the respiratory muscles, inspiratory and expiratory muscles, in addition to the diaphragm. The diaphragm is not shown here. Again, normally exhalation is passive, so muscles do not need to contract to push gas back out of the lungs. And then illustrated here is the effect of contraction of the intercostal muscles during inhalation, the effect of which is to lift upward and outward on the thorax. So the contraction of the external intercostal muscles causes the ribs to be moved upward and outward. So illustrated on this slide is the innervation of important respiratory muscles. So the diaphragm, for example, is innervated by the phrenic nerve, which arises from the cervical spine levels 3 to 5. So as you know, if a patient has spinal cord injury and there is a high cervical spine injury, the patient cannot breathe without ventilatory assistance. If there is injury to lower levels in the spinal cord, the patient will still be able to breathe because they can still use the phrenic nerve, but other respiratory muscles will not be active. And that has implications as far as a patient's ability to cough and use abdominal muscles and internal intercostals. And it also has implications for the position in which patients can breathe most comfortably. So if a patient has a high thoracic spinal cord injury, they can breathe with the diaphragm. They cannot increase their ventilation. They cannot cough effectively, and also they cannot support the chest wall during inspiration. And more on that in just a minute. If a patient has a low T-spine injury, they'll be able to inspire, okay, but will not be able to contract their abdominal muscles in order to be able to cough. So it's interesting then to think about the effects of body position and sleep on respiratory muscles, particularly with disease. So in individuals with diaphragm weakness, this might be a patient with ALS, for example, the patient can breathe more comfortably in an upright position. So patients with ALS typically have orthopnea, and in fact when they are in a supine position, there is a significant reduction in their vital capacity. And I've taken care of ALS patients who, in an upright position, may have a vital capacity that's not severely reduced might be 65, 70, 75% of normal. But when they are placed supine, because of the abdominal contents pushing up on the weak diaphragm, their vital capacity can drop in half. So when we have had patients in the ALS clinic who have complained of orthopnea and dyspnea, and we measure their vital capacity, it's not so bad. We put them down flat. It is much worse, and in fact, that will qualify them for BiPAP at night. The opposite of orthopnea is pladypnea, which I always have a hard time getting through my mouth. Pladypnea is difficulty breathing when flat, or being able to breathe, or difficulty, breathing when flat. It's the opposite of orthopnea. So difficulty breathing when upright. Did I get it right that time?
Yes, that time you got it right.
You all sat there, you were willing to take anything I said. So orthopnea, difficulty breathing when flat. Pladypnea, difficulty breathing when upright. So this tends to occur with spinal cord injury. And the reason for that is that with spinal cord injury, the patient cannot, particularly with like high thoracic spinal cord injury, the patient cannot use their accessory muscles. So they are dependent entirely on the use of the diaphragm. And when they are supine, the abdominal contents push up on the diaphragm, which is working, and with the diaphragm up here, when they contract the diaphragm, they can move more gas into the lungs than if they are upright, where the abdominal contents drop, their diaphragm is down here, and when it contracts, they don't move as much gas into the lungs. So orthopnea, difficulty breathing in an upright position, diaphragm weakening, pladypnea, difficult breathing when supine, spinal cord injury here, the vital capacity tends to be lower, upright than supine. And when patients with spinal cord injury get out of bed into a chair, for example, an abdominal binder will help. So often these patients will have an abdominal binder, which is placed, which is the effect of being flat and having the abdominal contents push up on the diaphragm. Now, it's also interesting to note that the accessory muscles are paralyzed during REM sleep. And for you or me, that's no big deal. So we go into REM sleep, our accessory muscles aren't working, but our diaphragm works fine, so we continue to ventilate based upon the use of the diaphragm. However, in individuals with diaphragm paralysis, they will have hypopnea, decrease in ventilation, during REM sleep. So in that patient with ALS, for example, that's a problem when they fall asleep because their diaphragm is weak, their accessory muscles don't work, and they have periods of hypopnea, which is why they get placed on BiPAP at night. And it is important that when they're placed on BiPAP at night, that they're put on a mode with a backup rate, because if they are put on mode without backup rate, they will continue to be hypopneic.
So why are respiratory muscles paralyzed during REM?
Because that's the way God made us.
I understand.
Yeah, I don't know what is the
physiology.
I don't know
what
what
is. Think of why is that important?
Yeah, I don't know why that is adaptive.
Right.
So, yeah, I don't know why that is adaptive.
Okay.
But often patients with neuromuscular diseases like ALS will have sleep disturbed.
Right.
Increases in PCO2 and desaturations and so forth. And it's because their diaphragm is weak or paralyzed, and then when they lose the use of their accessory muscles,
they're in big trouble.
Just don't breathe. But I don't know what the adaptive mechanism for that is. So the difference between the pressure in the stomach, in the abdomen, and the pressure in the thorax, or esophageal pressure, is the transdiaphragmatic pressure. And normally the way that this works is that the diaphragm, or during inspiration, the diaphragm contracts downward. That causes the intrathoracic pressure to become negative. So that draws breath into the lungs and we get a tidal volume. And the abdominal pressure increases and that pushes the abdomen outward. So normally as we are breathing now, our diaphragm contracts and the intrathoracic pressure becomes negative, the intra-abdominal pressure becomes positive, and our belly goes out. So that's the normal thing that happens with all of us. So what happens with diaphragm paralysis? Well, with diaphragm paralysis, the diaphragm is just here flapping in the breeze. The intrathoracic pressure becomes negative because of the accessory muscles. So the external intercostals and accessory muscles contract. That causes the intrathoracic pressure to become negative. That sucks up on the diaphragm, which causes the intra-abdominal pressure to become negative. So with normal diaphragm function, the belly goes out during inspiration. With diaphragm paralysis, the belly goes in during inspiration, which we call respiratory paradox. So if you observe a patient breathing with diaphragm paralysis, they breathe like this. And I have a video of that in a minute. So something that, for example, we would always assess on our patients in the ALS clinic. So here is a patient from the RACU many years ago. So this is probably 15 years ago now. So we published this in 2005, so yeah, probably about 15 years ago. And this was a patient who would not wean off of the ventilator. The patient had paradox. We assumed that the problem was that the patient had diaphragm paralysis. And we thought that was the result of the surgery that she had received. So what I did was I put one balloon in the esophagus to measure intrathoracic pressure. And I put in a second balloon in the stomach to measure gastric pressure, intra-abdominal pressure. So normally, what should have happened if we did this on you? What should happen as you're breathing in? What would you expect the esophageal pressure to do? Go down. And what would you expect the gastric pressure to do? Go up. But notice in this patient, the esophageal pressure goes down during inhalation when flow is positive. The gastric pressure goes down as well. And in fact, these two tracings could probably be nearly overlapped. So the gastric pressure has gone down, the intra-abdominal pressure has gone down by nearly as much as the esophageal pressure. So that confirmed that she had diaphragmatic paralysis. And in fact, fortunately or unfortunately, she decided to have life support withdrawn because she didn't want to spend the rest of her days with trach tube. Now, we can get at this information without putting in catheters. So those of you who know me, you know that I love to put in esophageal catheters. So this kind of an exercise was a lot of fun for me. But we don't need to put in balloons and catheters and so forth to do that. We can assess changes in intra-abdominal pressure by changes in bladder pressure. So changes in bladder pressure are due to respiration. And we would expect that the bladder pressure, if we're measuring that, would go up normally during inspiration, go down during exhalation. And we can assess intrathoracic pressure by looking at respiratory variation in the central venous pressure. So normally, during inspiration, the CVP goes down. During exhalation, it goes up. So if our patient has a Foley catheter and our patient has a CVP catheter, we can assess this just by looking at relative changes in bladder pressure and intra-abdominal pressure. So has any fool ever done such a thing? Well, I have. So here's actually a patient from about 10 years ago who was in the SICU right next door. And she was failing spontaneous breathing trials. And somebody observed that in her spontaneous breathing trial, her belly kept going in on every breath. So she was having paradox. So we transduce the bladder pressure, which is this line. Patient has a CVP, transduce the CVP. Here is respiration, inspiration, exhalation, inspiration. And look at what happens. When she breathes in, the CVP goes down, the intrathoracic pressure goes down, the bladder pressure goes down by the same extent. And this gives a pretty strong suggestion that there is diaphragm paralysis. So here's another way that we can look at this. So this was another patient in Iraqu a number of years ago, and this was before I had an iPhone, so I actually brought in my video camera from home to do this video. So this is what diaphragm paralysis looks like. So here's a patient, diaphragm paralysis. The ventilator is set on 0/0. And you can see the abdominal paradox. So when he breathes in, his chest goes out and his abdomen goes in. So look at the paradox. And then we reasoned that if we put a little bit of air, like an air bubble, into his Foley catheter, we could see which way the urine went during inspiration and exhalation. So here's his Foley catheter. So you see the urine going back and forth, and as it turns out, this is inspiration and exhalation. So now you'll be able to see that when he breathes, his chest goes out, his belly goes in, and when his chest goes out, the urine goes towards him. So normally, the urine should go away from him, because if he's contracting his diaphragm, the intra-abdominal pressure would go up, the bladder pressure would go up, and it would push the urine in the opposite direction. And we were so fascinated by this, we did the video from all kinds of different directions. So you can certainly
Dean, you gotta get a life, Dean. You gotta get a life.
So I don't know if any of you were around. Were you around, Nancy or Carolyn? So I don't know who was working in Iraqu during those days. But you can imagine this is something that I did with Bob Brown, who was very excited about the whole thing. So if your patient has a Foley catheter and you suspect that the diaphragm's not working, you can put a little bit of air into the Foley catheter. Lots of times there's some air there already anyway. You don't even have to put any in. And you can see which way the urine goes as the patient's breathing. And by the way, this has to be the Foley catheter unobstructed. So we've done this in the MICU sometimes, where the nurses want to clamp the Foley catheter because that's how they do bladder pressures. But here, you can't put the clamp on. You have to let the urine move freely. This, by the way, is something that I think probably occurs much more frequently than it's appreciated, where patients have diaphragm dysfunction, either which is acquired during their stay in the ICU or in the ventilator, or it may have been acquired because somebody's doing surgery in their chest and damaged the phrenic nerve, or it could have been potentially long-standing.
So if the Foley catheter is at the level of the bladder, is the distance the bubble moves equivalent to the change in bladder pressure?
Yeah, it should be. I never tried to be so quantitative, but
come on, Dean.
so I never like taking a tape measure and a Sharpie,
and see how much it moves.
But it is kind of I think a cool thing, cool physical assessment.
Well, it doesn't require you to do nothing except see the Foley.
Correct. Right.
That's all.
The only thing you have to do sometimes is you have to
get level.
And if the bladder's empty, you have to put in maybe 50 or 100 milliliters of saline, which is what they do when they measure bladder pressure. Yeah, so it doesn't, it won't work if the bladder is completely empty. So a term that has recently come into the literature, I believe just over the last 10 years or so, have you heard about this since maybe 10 years ago?
I don't even think it's that long, Dean.
So this is something called ventilator-induced diaphragm dysfunction, or VID. And what this is diaphragm weakness that results from controlled mechanical ventilation. And by controlled mechanical ventilation, typically it means that the diaphragm and the respiratory muscles are not contracting at all. So this is usually the patient has been paralyzed for a long time. So it's a result of a prolonged pharmacologic paralysis of the respiratory muscles. This is attenuated during patient-triggered modes of ventilation. So it has been suggested, for example, that if a patient is on assist control and just occasionally triggers the ventilator, that could attenuate the risk of ventilator-induced lung injury. So they don't have to be on support or making big efforts and so forth. Whether VID actually contributes to ventilator liberation failure is unknown, but I suspect that sometimes it does, but it hasn't been studied very well. So then it certainly makes sense that to the extent possible, it would be wise to avoid prolonged use of paralysis in patients with respiratory failure. Now, in the big study that was done a few years ago, which is now being repeated by the ARGNet Kettle group, where they did paralysis for ARDS, it was only 48 hours of paralysis. And the reason why it was short-term paralysis was to avoid this kind of an issue.
So how close is that study to being done? Do you know? How many patients more they got?
I think it's done.
Oh, it is.
I think it's done, and I heard that the results will be available by the end of the year. So all of us, every one of us in this room, has measured respiratory muscle strength at some time or another. Some of you maybe earlier today, I don't know. But this is what we do when we measure maximum inspiratory pressure, or what we commonly call MEP, or maximum expiratory pressure, which we commonly call MEP. And as you know, we use a valve system so that we can measure the MEP at residual volume, and we can measure the MEP at total lung capacity. And the reason for that is that the amount of force that can be generated by the muscle is determined by the length of the muscle. So when the length of the muscle is nearly at 100%, we can get the maximum amount of force. So for inspiratory muscles, like the diaphragm, that's a residual volume. So push out, that's where we can generate the maximum amount of force. And for expiratory muscles, we generate the maximum amount of force from total lung capacity, because that corresponds to maximum length of the muscles. So if a patient has a decrease in MIP, the patient needs ventilatory assistance. If the patient has a decrease in MEP, that means that the expiratory muscles are weak and the patient needs cough assist. So this explains why in patients with neuromuscular disease, they go on BiPAP and they get the cough assist device. And for example, in the neuromuscular clinic, in the ALS clinic, the vital capacities are monitored at every clinic visit. And typically the patient is started on BiPAP when the vital capacity drops to about 50% of predicted. So how much MIP and MEP should you be able to generate? So here are a couple of studies done over the years looking at normal values for MIP and MEP. So you can see that for males, most males can generate a maximum inspiratory pressure of negative 100 centimeters of water or more. Bob can probably do 180. Vinny can probably do 185. And expiratory pressures, notice that maximum expiratory pressures are greater than inspiratory pressures. And again, a little bit greater for males than females. But for males, for example, can generate expiratory pressures maybe of 150 to 200 centimeters of water. Females, probably 100 to 150 for expiratory pressures. So when we put this into context, you think about it, when we measure the MEP on a patient out on the wards and it's minus 30, that's a significant amount of respiratory muscle weakness.
So there's big differences between the top two and the last one.
Correct.
What's the difference in the study? What did they do different?
Yeah. So I'm not sure But the study that the normal values that are often used, like in a pulmonary function
Right.
lab, are the ones by Black and Hyatt. So those are the ones that people most commonly refer to. So here's a study done many years ago looking at the relationship between respiratory muscle strength and PCO2. And the point that I want to make here is that your MEP has to drop to at least about 50% of predicted before the PCO2 goes up. And in fact, for the PCO2 to exceed 45 millimeters of mercury, which most would say is still within the normal range, the MEP needs to drop to about 25% of predicted. So there is tremendous reserve in respiratory muscles as far as protecting against hypercapnia. Okay, so the next thing we want to talk about is the pressure-volume relationship within lungs. So if we took out your lungs, we took out Vinny's lungs, can't take out my lungs because then I wouldn't be able to do the lecture. Now you took out the lungs, you put them in a jar, and you hooked them up to a container here where we can measure volume, and we can measure the pressure change in the container. And then we start sucking air out of the lungs. So we keep sucking air, making the pressure outside the lungs more and more negative. There is an increase in volume, as you would expect. And notice that the relationship between the volume and the pressure is sigmoidal. Kind of looks like the O2 dissociation curve. So here, the curve is steep. Here it is less steep at lower volumes, less steep at higher volumes. You can also see if we do the experiment where we completely inflate the lungs and then we slowly deflate the lungs, how the lungs deflate is different than how they inflate. And that's something that is called hysteresis. And I don't know what the mechanism for that is either, Bob. I don't know what the adaptive mechanism is.
You know that. It's surfactant.
So it maintains lung volume.
Right.
So, but this is for normal lungs. So we'll talk a little bit more about this in sick lungs probably on the next lecture, because this relationship is different for ARDS. And the things that affect this relationship in ARDS is different than what it is in normal lungs. So yeah, for sure in ARDS it maintains lung volume, but the mechanism is probably a little bit different than this. The slope of the pressure volume curve is compliance. The change in volume related to the change in pressure, so the change in Y over change in X. So the slope of this curve is the compliance, and sometimes this is called a compliance curve. So notice that the compliance of the lungs is less at low volumes, it's less at high volumes, and the compliance of the lungs is best at about a normal volume where we're breathing. And a normal lung compliance is 200 milliliters per centimeter of water measured at functional residual capacity. Now some of you may wonder why that's 200 rather than 100, because you're probably taught that normal compliance is 100. Now we'll explain that in a minute. The relationship between volume and pressure, the compliance curve shifts with disease. So with emphysema, the compliance curve shifts to the left because there's alveolar destruction. So there's less elastic recoil pressure. With emphysema, the lungs are more compliant. Greater change in volume for change in pressure. With pulmonary fibrosis, restrictive lung disease, there is lower compliance, less change in volume for change in pressure. So the compliance shifts with disease, and it shifts with ARDS, and we'll hold that discussion for the next time. So then, what are the physiologic causes of the pressure-volume curve? Or put another way, what are the contributors to the elasticity of the lungs? And that is a little bit due to elasticity, the elastic tissue, which is in the interstitium of the lungs, but it is mostly due to surface tension. So in normal lungs, the pressure-volume relationship, that PV curve that I showed you, is primarily the result of surface tension. And in fact, it turns out that if we inflate the lungs with saline, I don't know if anybody wants to volunteer for that experiment, but if we inflate the lungs with saline instead of with air, it is much easier to inflate the lungs. Look at how much more compliant the lungs are with saline inflation as compared to air inflation. So there's something then about the air which is in the lungs, or the air fluid interface within the lungs, which contributes to the shape of the pressure volume curve, and that is the result of surface tension.
So remember when we tried liquid ventilation? That's the reason why people believed it would work. It's exactly what Dean just said. But it didn't.
Nope.
Right, there are some unintended consequences.
Correct.
Could be a whole other talk. So then, what is happening with surface tension? So how does surface tension affect the ability to inflate the lungs? Well, if we look at the surface of a bubble or a sphere, so an alveolus would be like a sphere, the molecules that are at the surface are going to be drawn inward. And the reason for that is that molecules away from the surface are drawn in all directions by surrounding molecules. The molecules at the surface will be attracted to the molecules beneath them, but there are no other molecules up here in the air layer to counteract that effect. So the effect is that the molecules at the surface will be drawn inward. If the molecules at the surface are drawn inward, then the size of the area of the surface of the droplet or the sphere will decrease. So the effect of surface tension will be to make the sphere or the bubble as small as possible, because these molecules are being drawn away from the surface. And that is described by something called the law of Laplace, which says the pressure within a sphere is proportional to the surface tension divided by the radius. So that means that if we have two spheres that are connected, as is shown here, the smaller sphere, lower radius, will have more pressure than the larger sphere, so the small one should collapse into the larger one if they are connected, as I showed here. So then, why don't all of our alveoli collapse into the largest one in the lungs? Because what this would say is that all the smaller ones should collapse and all the air should go into one alveolus, or we just end up blowing up one alveolus till it would burst. Because we have, unless you work in the NICU, surfactant. So surfactant counteracts this effect. So surfactant are soap-like molecules which line up here along the surface, and it interferes with the surface tension that occurs as a result of these molecules diving towards the center. And surfactant is distributed among the walls of the alveolus in a way so that when the alveolus gets smaller, the concentration of surfactant molecules increases. So if you think about having the same number of molecules here as you have here, if you make the sphere smaller, there will be a higher concentration of molecules. So then what happens is, as a result of surfactant, and I tried to draw this with the heavy line versus the less heavy line, that with a decrease in radius, the surface tension decreases proportionally, because surface tension, surfactant reduces surface tension. So for you and me, we have alveolar stability. The little alveoli do not all empty into the biggest alveolus, because the surface tension is going down as the alveolus gets smaller. So then we need surface tension Yeah, we need surfactant. We also need surface tension. We need the right balance between surfactant and surface tension. So we need surfactant to increase the overall compliance of the lungs, to maintain alveolar stability, as I showed on the previous slide, and to keep the lungs dry, because the surface tension draws water, because surface tension tends to draw water into the alveolus. So we need actually the right balance between surfactant and surface tension, because surface tension is what pushes gas back out of the lungs during exhalation, as well as elasticity. But if we have too much surface tension, then we get collapse. Now it turns out that in the thorax there is a pleural pressure gradient. And what that means is that the pleural pressure, which is negative, is not evenly distributed throughout the thorax. And the pleural pressure is more negative at the top of the lungs than it is at the bottom of the lungs. Or in an upright position, the pleural pressure is more negative at the apex than it is at the base. So there are several consequences of that. One is that alveoli at the top of the lungs are larger. And if you think about a patient with COPD who has alveolar destruction, where do the blebs and bullae occur first? The top of the lungs. So the alveoli at the top of your lungs are bigger than the alveoli at the bottom of your lungs. The other thing is that most of the ventilation goes to the bottom of the lungs. So if you look at the diagram where the intrapleural pressure is less negative, is going to be towards the bottom of the lungs, which is on a more compliant part of the pressure-volume relationship. Whereas alveoli near the top of the lungs, where the pleural pressure is more negative, are on a part of the pressure-volume curve that is less compliant. So these alveoli ventilate more than these alveoli. So in your lungs and in my lungs, right now, as we're breathing, our alveoli are bigger at the top of the lungs than at the bottom of the lungs, but most of the ventilation is going to the bottom of the lungs. And if lung volume is reduced, or any one of the many clinical things that can reduce lung volume, the alveoli at the bottom of the lungs are going to collapse before alveoli at the top of the lungs, again because of the pleural pressure gradient. So the dependent alveoli are the ones that are going to be most likely to collapse with lower lung volumes. So now let's think about this in relationship to something that we do clinically, which is to place patients in a prone position. So let's look at supine versus prone. So let's look first at the supine relationship, where we can think of the lungs as being like a cone, and we can think of the chest wall as being like a cylinder, and then we squish this cone inside the cylinder, so that deforms the lungs, changes the shape of the lungs, and then as a result of changing the shape of the lungs, notice that the alveoli here are smaller at the bottom than at the top. And then if we add gravity, so that we get our pleural pressure gradient, we end up with alveoli that are very big at the top of the lungs, much smaller at the bottom of the lungs, and dependent upon lung volume may be collapsed at the bottom of the lungs. So the geometry of the lungs is like a cone, the geometry of the chest wall is like a cylinder, and the effect of geometry and gravity is to promote dependent alveolar collapse in the supine position. And that is illustrated here from some data which is a number of years old now, showing that at the top of the lung, which is where most of the air is, at the bottom of the lung there is much less gas, air, and in the supine position it makes it worse. So we get dependent collapse in our patient with ARDS. So now what happens if we turn the patient prone? So now again the lungs are a cone, but it's an upside down cone. Again, the lungs get squeezed into the thorax, which is a cylinder, And now the pleural pressure gradient is less negative. So it's still more negative at the top and less negative at the bottom, but the extent of that gradient is much less, so that now dependent alveoli may be less prone to collapse. So the effect of geometry and gravity is to oppose dependent alveolar collapse in the prone position. So that's going to result in a couple of beneficial things in patients with ARDS. So one is it's going to improve gas exchange, and the other is it's going to reduce the amount of lung injury by maintaining volume within these dependent alveoli. And that is illustrated again by this figure, which is at least 10 years old now, and maybe older. So you can see that the gas volume difference between the top of the lungs and the bottom of the lungs, it's much less in the prone position than it was here with the supine position, particularly in patients with disease. So that's why prone positioning works. Agree with that?
Agreed.
So that's just illustrated a little bit different way here. So in a patient with ARDS, in the supine position and the non-dependent regions, the ventral regions of the lungs, the pleural pressure is negative in the dorsal regions of the lungs. It may actually be very positive with ARDS, resulting in dependent alveolar collapse. We put the patient prone. The pleural pressure gradient from top to bottom is much less, may remain negative in the ventral down parts of the lungs, and maintain alveolar recruitment.
You think it's that big a difference normally? You know, typical patient,
well, you mean in patients with ARDS?
Yeah,
not normally. Not in you and me.
But even in ARDS, the difference becomes less. But that's a huge change you're talking about.
Yeah, I think it depends upon. That's
a 17 centimeter water change. That's a lot.
It depends upon how edematous the lung is, I think. So.
Okay.
But we could just say negative, positive, and even if this is a little bit
less positive, or negative,
even if
right.
this is a little bit of an exaggeration,
yeah.
The effect is, I think, the same overall. So the effect of prone positioning then is to prevent dependent alveolar collapse. And that results in good things as far as gas exchange. It's what we like to see at the bedside, but it's also good as far as ventilator-induced lung injury. Okay, so what about chest wall effects? Well, the effects of the chest wall are that, so we've already talked about that the lung is trying to collapse inward. And the reason why the lungs are trying to collapse inward is primarily due to surface tension, a lot of which, but not all of which, is counterbalanced by the effect of surfactant. The effect of the chest wall is to expand outward. So we have the lungs that are trying to go like this, and the chest wall, which is kind of trying to go like this. So the pressure between the two is negative. So normally the intrapleural pressure is always negative because of the opposing outward effects of the chest wall and inward effects of the lungs. So if you get a pneumothorax, for example, then, as you know, air is sucked into the pleural space, collapsing the lungs, allowing the chest wall to move outward. And in fact, one of the clinical signs of a pneumothorax is that when you look at the thorax looks bigger on the side of the pneumothorax because the chest wall expands outward. By the way, I'll ask you my question I used to always ask the fellows. Some of you may have heard this before. So if a buffalo is running across the prairie and you shoot the buffalo in the side, the buffalo takes 10 steps, falls over dead. We've all seen it in the movies, and that's what happens. But if I hang out in the wrong area tonight and I get shot on one side of my chest, I get a pneumothorax on one side, and likely I survive because I get transported to the emergency room and the chest tube gets put in, I survive. So what's the difference? So why does a buffalo immediately fall down dead if they're shot in the side, and humans do not? The reason is, what?
The Sears membranes. Isn't there thoracic cavity all one? So if
Correct,
this is
exactly. So a buffalo has a contiguous pleural space. So when they get shot in the chest, it collapses the right lung and the left lung. So both lungs collapse, the intrapleural pressure becomes very high, venous return decreases, and diabetes. But for you and me, we have separate pleural spaces of the right and left. So the one lung collapses and the other one does not.
So
Were you around when I used to ask that question all the time?
I'm trying to remember. I mean, I agree with you, but is it all four-legged?
I don't know. I don't think so. I think it's
Dogs,
just,
it's not,
right. I think it's
for sure.
I think it's unique to buffalo.
Okay.
So the
Remember,
and the
this is
mechanism
Good thing to clog up my
This is
phone.
and the mechanism is to feed the natives.
So it's easier to bring down the big buffaloes. Okay?
At any rate, a little bit of trivia. I have more, but I won't bore you with them today.
You will.
Okay, so since we're going to do 2 weeks on mechanics, I'll go through this slide and then we'll drop and we can, the next time we can get caught up to this point and then go through the rest of the lecture. So let's imagine that we take Vinny's lungs again, we take out of his thorax, and we put them on the table, and we cap the lungs, we cap the trachea, and we inflate the lungs. What you can see is as the lung is inflated, there is always a positive pressure. So as we cap off the lung and we push more and more volume into the lungs, the pressure we measure in the lungs is always positive. Because the tendency of the lungs is to collapse inward. But now let's say we took Vinny's chest wall without his lungs, and we put his thorax on the table, and we do the same experiment. So we keep pushing air into the thorax without lungs. You can see that except at very high volumes, the pressure in the chest wall in the thorax by itself is always negative. So the chest wall is trying to spring out, the lungs are trying to collapse inward. Now if we put them both together, put the lungs back into the chest wall, you can see that at some lung volumes, the pressure is negative. Some lung volumes, the pressure is positive. And at functional residual capacity, which is this line, at functional residual capacity, the outward effects of the chest wall completely counteract the inward effects of the lungs so that the airway pressure is zero. So why do we stop exhaling at FRC? Taking a breath, exhale passively. Why does exhalation stop where it does? Well, it stops when the outward effects of the chest wall are completely balanced by the inward effects of the lungs. So the isolated chest wall expands outward, except at very high lung volumes. The isolated lung collapses inward. At functional residual capacity, the alveolar pressure is zero. The pleural pressure is negative. And in fact, physiologic PEEP is zero. There is no such thing as physiologic PEEP. Lots of good reasons to put patients on PEEP, but not because it's physiologic, because the physiology says that normally at end exhalation, the alveolar pressure is zero. So a little bit of math, so you know I like math. So a little bit of math, it turns out that the normal lung compliance is 0.2 liters per centimeter of water, 200 milliliters per centimeter of water, which I had on a previous slide. Happens that the chest wall compliance is also about 200 milliliters, 0.2 liters per centimeter of water. But a normal respiratory system compliance is half of the lung or the chest wall by itself. So you have probably all been taught, even if you've forgotten, you've all been taught at one point or another, a normal compliance is 100 milliliters per centimeter of water. That's respiratory system. The compliance of the lungs or the chest wall by themselves are twice that. So why is that? How can you put them together and it is less than either one by itself? So Bob is making motions to indicate that it's because the chest wall is going out and the lungs are going in. Mathematically, this is the relationship. So the elastance of the respiratory system is the elastance of the lungs plus the elastance of the chest wall. Both together. By definition, elastance is the inverse of compliance. So if you put in 0.2 for lung compliance and 0.2 for chest wall compliance, and you remember how to do your math of fractions, it turns out that the respiratory system compliance is half of what is the compliance of the lungs or the chest wall by itself. Okay, so I will stop there. That is actually a good place to stop, because the next thing we have to talk about is airways resistance. And we'll pick up with this on the next time, and then I'll segue into discussing these things as they apply to a ventilated patient. And we'll get in more to pressure volume curves with patients with ARDS and so forth, because the mechanism's a little bit different there than it is with lungs. Okay then, till the next time.